Well, our second student to present today is Dr. Sam Sussmes, and he's a medical graduate from Oxford University, volunteered with us during a gap of several months this year before he goes to Australia for a further year of training. He has a special interest in cardiology. His project with us was to study the management of excessive overgrowth, which is quite controversial, the management. For his work, he's been awarded the Dr. Michael Carr Memorial Scholarship by the Marfan Trust. Dr. Carr was a much admired and respected former chairman of the Marfan Trust, who encouraged the trust to support education and to make sure that all our doctors know about Marfan syndrome. Sam, you're going to tell us about overgrowth?
Yes, sure. Hello, Dr. Child. Hello, everyone. My name's Sam, as Dr. Child said, and I'm a foundation junior doctor, and I'll be talking about the topic of growth management in Marfan syndrome. So, as I'm sure you're all aware, typically Marfan's patients are tall. They can be really quite tall, and so there are concerns, or there may be concerns around somebody's height. The first of these really is this day-to-day impact of being tall, and this is quite subjective, so this varies from patient to patient as what affects them. So that may be finding the right trousers, finding the right length of trousers, or finding public transport seats that are comfortable. And so it's quite subjective as to what impacts on somebody's life. The second concern really is perhaps a little bit more important, the medical concerns of being tall. And unfortunately, it's not really known whether there is if there are these medical concerns about being tall, just because there hasn't been extensive research on the topic really. But certainly cardiologists do question whether taller Marfan's patients are more at risk of the complications of things like a dissection of the aorta. But as I said, there's no evidence at the moment to suggest that, or to show it, sorry. It's just a thought. So has anything been tried for Marfan's patients? Again, unfortunately, there's no formal consensus within the medical profession about what to do with Marfan's patients who are expected to be or predicted to be taller than average. It's really quite a grey area, so it's dealt with on a sort of a case-by-case scenario. But overall, really, treatment is uncommon. It's certainly not routine. However, there are two strategies that can be tried for children of tall stature, and this is children of tall stature from any cause, not just Marfan's. And so these are hormones and then a surgical operation. There's not masses of studies out there in the literature, and not all are particularly conclusive. And it's also worth saying that the results are quite variable. So some children who have these, some tall children who have these treatments may not show any reduction in their height, but some may show a significant reduction in several centimeters of height. So it's incredibly variable. So the first of these is hormone treatment, and this involves exogenous sex hormones, so estrogen and testosterone, for a period of several years through puberty. And the idea is to speed this up so that the children achieve their final height quicker. It's considered that early treatment is best, which obviously presents a bit of a challenge if Marfan's isn't diagnosed until a little bit later on in childhood. It used to be used more frequently. It's pretty uncommon now because of the side effects and the considered too much for the treatment, really. So they're quite significant side effects, things like blood clots, high blood pressure with these sex hormones, which obviously in Marfan's, if you've got a fragile aorta, we want to keep the blood pressure lower. And there's certainly some evidence to suggest that with females, having these steroids earlier in life does predispose them to certain cancers later in life, and also reduce fertility. So the other treatment or potential treatment is a technique called epiphysiodesis, and this is an operation performed by an orthopedic surgeon. And this is where the growth plate, so this is the growing part of a long leg bone, is operated on, and that stops the growth. And nowadays, surgeons can do it fairly, what we call minimally invasive, so not requiring a big open procedure on the leg. Generally considered to have fewer side effects compared to the hormones, but obviously it does involve going through an operation, and so there's surgical risks of any operation, as well as an anaesthetic. Epiphysiodesis can only happen up to puberty because of the growth plate. At the end of puberty, that growth plate won't be there. But there is potential that limb shortening surgery can happen later on. So after puberty, the height of a child may be able to be reduced by this limb shortening surgery, which is slightly different to epiphysiodesis. So those were the two potential strategies that are used in children of tall stature to manage their height and to reduce their height. Both are really quite uncommon. They're certainly not routine. And it's specifically, it's not for Marfan's, it's for children of tall stature in general. But what does this mean practically for Marfan's patients, and what can be done? The key point is a referral to a pediatric endocrinologist if there are concerns about height and about growing too quickly. And this, so an endocrinologist is a specialist doctor who looks at hormones and growth, and they are the best people to assess the child's growth. And this referral normally comes from the clinician who is overlooking the overall care of the Marfan's patient. So whether that's a GP or a paediatrician in a local district hospital. And then once that referral has been made, what's needed is a thorough discussion between the child, the parents, and the endocrinologist about what really the concerns are about a tool, about being tooled, and what can be expected from treatment if there is any treatment that is available. And then what needs to be decided is to weigh up the risk of the side effects and any complications against the benefit of how much height may be reduced. Often this figure of 150 centimeters is talked about as being the time to refer. Some endocrinologists do use this as a sort of as a rough guidance. Other endocrinologists tend not to, because it's difficult to assess each child at what stage of puberty they are. So 150 centimeters at an early stage of puberty is quite different to 150 centimeters at a much later stage of puberty. But it can be something to think about as a sort of a ballpark. What can be done for sort of the parents? So what's really helpful is recording annual height measurements, and then if a referral is made to the endocrinologist, taking along these measurements, as this helps to assess or to predict the expected final height. And also, given that Marfan's is often involves lots of different specialties involved in the care, it's important that the whole team, so the cardiologists, the genetics, are all aware of the decision if treatment is chosen. So that's all my presentation. Hopefully that gives some sort of background information as to what potential treatments there are, and how about sort of exploring that. And the key point is the referral to an endocrinologist who overlooks that and oversees that decision making about treatment. Thank you.
Well done, Sam. That's a very complicated area. If you ask patients how tall is too tall, the answer I get back is, for the men, is 6'8". They say that's the very tallest anybody should be expected to be. And what they worry about is that they don't. I had one chap say to me, "I don't fit in the world." That's kind of a sad statement, but you know, I think he was right, because he couldn't find a car big enough. So he used to ride a bicycle to work every day of the year. It didn't matter if it was snowing or icy, he had to ride his bicycle. He didn't fit in airplane seats. He had to pay a lot of money for his suits and his shoes. And he had the usual problems of being teased at school. But there you are, 6'8" seems to be the answer. And I had another patient of 6'8" who actually went for the third possibility, which is to remove a bit of the leg bone. And the surgeons took 2 inches from his tibia, both sides. And he came back to see me afterward. And I said, "How do you feel about it now?" And he said, "Magnificent," with a big grin, because at last he felt he was the height he should be. So that's interesting. If we ask the patients, you know, do you want treatment? The answer is going to be different from different people. Any questions from the audience?
Nothing's yet emerged, no, that I can see.
I've got a question. Yes, I very much enjoyed that talk. That was very informative. It's such a difficult topic, so thank you very much. My question to you, Sam, is if you were in this position, which would you choose? Would you choose to be extra tall, or would you choose to have the orthopedic surgery or the hormone treatment? Because we don't have any trials, as you've shown, to compare them. So what would your choice be? Because I'm very interested to know what people think would be best. And if we have any patients who've actually undergone these procedures, their feedback is very helpful to know what to do best. Because obviously, if you refer to an orthopedic surgeon, they'll do the orthopedic treatment. And if you refer to an endocrinologist, they'll go the endocrine way. So to a certain extent, that is involved in the decision as well.
Yes, definitely. Yeah, it's a very hard question for me to answer. I think I guess because we don't know really if there's medical concerns about being tall. At the moment, the main concern really is that subjective point of view as to how height impacts somebody. So if somebody can live with the fact that their trousers and are difficult to buy for, and seats are difficult to find. And if I could live with that, I would probably live with that. And then I think it would take a long decision speaking to an endocrinologist, if I wanted to go down that treatment line. I think probably maybe the surgical route has fewer side effects. But I think the main decision to be made is treatment worth it for potentially several centimeters, and will that really impact someone's life, and does that solve the problems that they're having? Yeah, so not a particularly clear answer, but
no, that's very helpful. Thank you.
Mrs. Jenny Carr, Michael Carr's wife, is with us. Jenny, Michael was quite tall. How did he feel about that?
I know when he was growing up, he felt like a freak because he was so tall at quite a young age. And at the age of 11 and going to secondary school, still had to wear short trousers, and he was 6 foot tall at that stage. So I think it greatly affects the psychological side of things to do with Marfan syndrome, and the need for support in that sort of way. And I don't know quite what there was then, apart from his own family, but this feeling so very different to everybody else, certainly doesn't help in all this.
Would you like to say a few words to Sam? Because he's the first recipient of the Michael Carr Memorial Scholarship this summer.
Yes, I was very pleased to hear of the award, Sam. I know my husband Michael put so much into his role with the Marfan Trust as a trustee for many years, and then as chairman. He also has a scientific background, so was so delighted to hear of any research and encouraged it greatly. And he would have loved to have heard your talk about management of tall stature, I'm sure. So very delighted, and you're the first person with the award, and I'm sure you will carry it forwards with you, and you'll always have this greater knowledge of Marfan syndrome, and will be able to pass it on, and that's absolutely superb. Especially
since he's going to be a cardiologist.
Yes.
I think we've planted the question in his mind.
That's great.
Does growing taller affect the aorta, which has to keep up?
Yeah, and it just to add, it's very nice to hear you're an Oxford postgraduate student as well, because we happen to live nearby in Abingdon, so obviously we had treatment at the JR with the Dr. Alex picture there, so you may have come across. So that was another nice connection for me with you too.
Very nice to meet you too, Jenny.
Thank you, Sam.
Someone's just asked a question if it's possible to predict the height of young Marfan patients. They've been told different things by different doctors.
Yes, it's so predicting height in children, I think, is a very tricky job for an endocrinologist to do, and that's for children without Marfan's in the first place, and then on top of that, if somebody does have Marfan's or another syndrome, it's even harder to predict height. So there are several methods that can be used, but none are perfect. And that's one of the issues about weighing up whether treatment is worthwhile, is it's all based on a prediction of final height, which may or may not be achieved. So it is a tricky to get around it, but I think at the moment that's the best system they've got.
Thank you.
In London, we do have a young endocrinologist at the Hospital for Sick Children, Dr. Chesover, whom Sam has interviewed, and he's willing to take on this challenge. So if anybody's looking for pediatric endocrinologist opinion, Dr. Chesover is your man.